Ischemic mitral regurgitation is a complication after acute myocardial infarction associated with a worse prognosis. The pathophysiological mechanisms of ischemic mitral regurgitation are not fully understood, but it is known that it's a complex process in which ventricular remodeling is the main causal factor. Echocardiography has contributed significantly to clarifying the mechanism that cause and progressively aggravate ischemic myocardial regurgitation. Valvular involvement can be primary, organic, or secondary functional. Primary occurs after the rupture of the mitral subvalvular apparatus in the context of an acute myocardial infarction. Secondary is when the valve, leaflet, and chordae are structurally normal and myocardial regurgitation results from an imbalance between closing and tethering force on the valve secondary to alterations in the left ventricle geometry. In the symmetric closure pattern of ischemic mitral regurgitation, a hockey stick or seagull sign is shown on the echocardiogram. The anterior leaflet in systole is below the posterior, which is also stressed, altering the coaptation. An eccentric jet of insufficiency appears ipsilateral to the posterior leaflet, which goes to the posterior region of the left atrium. This pattern is typical of inferior or inferolateral infarction. The diameters of the left ventricle, the volume of the left ventricle by two-dimensional biplanar imaging, or more accurately with the three-dimensional imaging, and the sphericity index of the left ventricle must be determined. As for the deformation of the mitral apparatus, the most commonly used parameters are the size of the ring, the distance of coaptation, the angles of the leaflets, and the area of tensioning. Transthoracic echocardiography is an excellent method for assessing the mechanism and severity of ischemic mitral regurgitation, although with some limitation. A combination of two-dimensional echocardiography, spectral and color Doppler parameters from the standard approach to quantify the degree of secondary mitral regurgitation. Large central mitral regurgitation jets reaching left atrial roof and pulmonary veins suggest significantly mitral regurgitation. The vena contracta width in the parasternal long axis view is another measure of the severity with a cutoff of greater or equal to 0.4 centimeters, indicatives of severe mitral regurgitation. Calculation of ERA using the surface area of the proximal flow convergence is another approach to quantify mitral regurgitation. Transesophageal echocardiography is especially useful when the quality of transthoracic echocardiography is not optimal, since it allows a detailed evaluation of the morphology of the mitral valve and the subvalvular apparatus. In 2D2, the diameter of the mitral annulus can be quantified, as can the height and increase of the tenting area, as well as the traction and the decrease of the apposition surface. Three-dimensional 2 has been shown to be superior of 2D2 in the measurement of the area of the vena contracta, being useful in organic and functional mitral regurgitation, even with the several regurgitation jets. It allows automatic measurement of the PISA area, avoiding geometric assumption and more accurate calculation of the regurgitation volume and area. Finally, real-time 3D transesophageal echocardiography plays an indispensable role also to guide mitral valve annuloplasty and in the assessment and management of transcatheter mitral valve repair.